Everyone, today we're gonna solve SMLE question for medicine coronary artery disease. Okay, it's all about 24 questions. Let's start. Right. The first question says 34 years old, healthy man, concerned about heart disease. Which of the following is the most important risk factor for ischemic heart disease? So, as we know, from this, I guess the most important risk factor for ischemic heart disease is the blood pressure. Okay. If it's more than 140, so the most common risk factor here, this is if it was more than 140 over 90, but this is below, so this is normal. Two separate fasting plasma glucose of 8 and 8.3 millimole. So this will be the most common factor. Okay. So this is the explanation. I guess we don't need it. Only we will read this. Education objective: diabetes mellitus is the significant and prevalent risk factor for ischemic heart disease. So increasing the risk for the cardiovascular event mortality. The other options, it's obviously why it's wrong. Right. The next question: 55 years old, present with 3-month exertional chest pain. So he has previous history of myocardial infarction. Which of the following is modifiable risk factor in the treatment of ischemic heart disease? So family history, smoking, gender, BMI. So family history and gender, it's not modifiable risk factor. You cannot change your family history or your gender. BMI also is a risk factor, but the smoking is more stronger than the direct, and it's direct modifiable. So we'll go with the smoking. So here is a clear explanation. Smoking is the most appropriate answer for the modifiable risk factor. So we'll go next. 48 years old man, present with central and several and severe chest pain. Started around 1 hour ago. There is no radiation of the pain or associated shortness of breath. He has similar fleeting pain over the past 2 weeks, but this settled spontaneously after a few seconds. Which of the following is most likely diagnosis? So we can see here severe chest pain and settle spontaneously after a few seconds. What that mean? Okay. A gastroesophageal reflux, GERD disease. So GERD usually came with burning chest pain and related to the vales. So this is unlikely to be GERD. Myocardial infarction, pneumothorax. Pneumothorax, they will come with pleuritic chest pain. Anxiety is unlikely to be the diagnosis. So myocardial infarction is the correct answer. And this is clear questions. No need even to read this. Next question. This 65 years old woman with diabetes and hypertension, present with retrosternal chest pain at rest for 3 hours. Physical examination normal except for she has S4 gallop. So the blood pressure is normal, heart rate normal, oxygen saturation 95, troponin is 10. So it's very high troponin. ECG shows T wave inversion in lead V2 to V5, the anterior bleeds. Which of the following is the most likely the diagnosis? So the troponin is high and there is T inversion in the anterior lead. So this will be stable angina or unstable angina or elevation MI or non-STEMI. So when we see the troponin is 10, very high, so we're gonna go with non-ST elevation. So when you see the troponin is high, compare the normal of 10, and the ECG is Okay, there is T inversion. So the combination of elevated cardiac troponin and T wave inversion or ST depression without ST segment elevation is the definition of non-STEMI. So why the other answer is incorrect? The stable angina, you will be having uh, exertional chest pain relieved by rest. So and the cardiac enzyme will be normal. This is the most important thing. Okay, and this patient have elevated troponin and pain at rest. Unstable angina, okay, will have worsening of the angina at the rest. Normal cardiac enzyme. So this patient have troponin elevation, so it's not unstable angina. So STEMI, ST elevation, this patient have no ST segment elevation. So this is non-STEMI because troponin is high and there is no ST elevation, and he have chest pain suggestive acute chest syndrome and elevated cardiac enzyme. I'm just reading for you the questions and answer, not doing anything more than this. So this is the 5 questions. This is 52 years man diagnosed in the ER with acute inferior wall myocardial infarction. So he received morphine bolus and nitroglycerin infusion for several ongoing chest discomfort. 20 minutes later, and while preparation the patient for the primary BCI, his condition became worse. So his GBV at this time was elevated and his lungs were clear. Initial ER record, the blood pressure is 120 over 70, heart rate 90 and regular, respiratory rate 22, oxygen saturation 96. 30 minutes later, the blood pressure dropped, very low hypotensive, the heart rate 105, which of the following is the most likely the cause of the hypotension. So here we have morphine and IV nitroglycerin infusion. Then his condition became worse and became hypotensive. So is this cardiac tamponade or complete heart block or papillary muscle rupture or right ventricle infarction? So we will exclude the cardiac tamponade and complete heart block. Both of them will not cause the hypotensive with the decrease the preload of the nitroglycerin. Papillary muscle rupture would be unlikely in this case, so we'll go with right ventricle infarction. So this patient has acute inferior MI, so it's commonly caused occlusion of the right coronary artery, which also supply the right ventricle. So therefore, the right ventricle infarction is frequently complication of the inferior MI. So we keep finding pointing the right ventricle infarction causing hypertension. First thing, the inferior MI, which causes the right ventricle ischemia, administration of IV nitroglycerate, and it is vasodilator, so reduce the preload. The third thing is the elevated GBV and clear lung. It's a classic sign for the right ventricle failure. So when the right ventricle fails to pump the blood forward, causing backflow and back pressure into the systemic venous circulation, so lead to elevated GBV. Hypotension and tachycardia, the blood pressure dropped significantly from 120 over 70 to 75, with compensatory increase in the heart rate from 90 to 100. So the cardiac tamponade will be unlikely because we need the big triad. And the complete heart blocks can cause most likely will cause bradycardia and hypertension, not increase in the heart rate. Papillary muscle rupture typically will cause severe mitral regret and will present with acute pulmonary edema. So this case was clear lung, there is no cracks, and will cause a new murmur, not mentioned. So I guess this one is clear. So we'll go for the next question. Okay, this is 60 years old male. Present to emergency department with heavy retrosternal chest pain or retrosternal chest discomfort. The discomfort started 3 days earlier as intermittent brief episodes become more frequent and prolonged over the last 24. In the emergency, he experienced similar type of discomfort, 5 to 10 on the pain scale, which responds well to sublingual nitroglycerate. Serial cardiac enzyme are normal. ECG initial show ST depression in the anterior and lateral chest beats, which later normalized completely. Which of the following is the most likely the diagnosis? So these have previous episodes, and it's more than 24 hours. And he has also discomfort, which is bound well to nitroglycerin, and the cardiac enzyme is normal. So, is it unstable angina or acute pericarditis or myocardial infarction or acute aortic dissection? Okay, acute pericarditis will present with pruritic chest pain. The MI will never choose MI if the cardiac enzyme are normal. The acute aortic dissection will present with severe chest pain and radiated to the back. So this is most likely to be unstable angina. So the key features supporting the unstable angina: chest discomfort for the last 24 hours, response to nitroglycerin, and the cardiac enzyme are normal, so indicating no myocardial necrosis. And the ECG change show depression, not elevation. And this is the common ECG finding in unstable angina, which is transient ST depression. The other options we already discussed. This is easy one. Okay. The seven questions is: there is 62 years old, present with recurrent resternal chest pain, which he said has become much worse over the last 3 weeks. He described the pain as lasting much longer than before, and that it's occurred when he is sitting on chair or in bed, so at rest. At night reading, which of the following is the most likely type of angina? So it's worsening for the last 3 weeks, and pain is lasting much longer than before. So what's this gonna be? This is obviously will be unstable angina. A 39 years old presented a shortness of breath for 2 weeks. Symptoms associated with activity and relieved by rest. He is otherwise healthy, takes no medication, denies chest pain or pressure. Which of the following is the most likely diagnosis? Is this classical angina, or angina equivalent, or musculoskeletal pain, or myocardial infarction? If you ever see retrosternal squeezing chest pain, worsening by exertion or activity relieved by nitroglycerate, this is a typical angina. But whenever one of these 3 signs is missing, we will call it angina equivalent. So the angina equivalent might be present. This is the typical angina characteristic. It is retrosternal squeezing chest pain, worsening by exertion or activity relieved by rest or nitroglycerate. So if the patient have all these 3, this is typical angina. If one missing, for example, this patient complain of shortness of breath and fatigue, so will be most likely called angina equivalent and not classic angina. 62 years old, present to our clinic with recurrent episode of steel chest tightness, which occur mainly after heavy physical exertion. He has no chronic medical problems. Clinical examination has baseline ECG were normal. Which of the following is the most appropriate next step in the diagnosis? So this is old, 62, and has a recurrent episode. Recurrent episode of steel chest tightness, and this is high risk for coronary artery disease. Okay, the baseline ECG is normal. So the question is, what's the next step for the diagnosis? Is it exercise ECG, echocardiogram, ECG, or echocardiography, coronary angiography, or myocardial perfusion sonography? This is most likely will be exercised ECG. This patient highly suggestive of stable angina. So the diagnostic strategy starts with the symptoms, chest tightness, then normal baseline ECG, and ability to exercise. The patient's symptoms occur with heavy exercise. So implying will be they are able to exercise. I guess it's a clear, obvious question. Okay, this is 55 years. Man with diabetes present to a cardiology clinic with vague chest pain, with exertion for 2 months. ECG normal. Which of the following is the most appropriate next step in the management? So, first of all, this is diabetes and have chest pain with exertion. And the ECG is normal. So, should we reassure him? We do exercise ECG testing, coronary angiogram, or adenosine myocardial perfusion imaging. As we know, it's the same as the previous question, will be exercise ECG, and this is a stable angina who highly has coronary artery disease risk factor. Okay. This is 38 years old, has an episode of chest pain. He states that the pain feels like tightness, locate right behind the sternum. So last less than 3 minutes and relieved by rest. He takes no medication and has no family history of coronary artery disease, has never smoked, his ECG is normal. So which of the following, what is the most appropriate test to exclude the cardiac ischemia? How can we exclude the cardiac ischemia in patient that has episode of chest pain and less than 3 minutes and relieved by rest? So, and his ECG is normal. So, as usually, to exclude the cardiac ischemia, we have to do exercise ECG. The CT and other will not exclude cardiac ischemia. Okay, so this patient has a classic stable angina, as we all know. So for patient presenting with exertional dyspnea pain, symptoms highly suggest stable angina, even in the absence of traditional risk factor. With normal resting ECG, exercise ECG, the stress test is the most appropriate initial non-invasive test to exclude cardiac ischemia. Yes, this is clear. Sorry. 65 years old, diabetes, admitted to the coronary care unit, diagnosed with acute ST elevations anterior myocardial infarction. He developed massive hematemesis following streptokinase infusion. Which of the following drug would reverse the action of streptokinase? So, this you have to know it. The antidote for streptokinase is the amino carbonic acid. The other, by excluding, you can exclude them. So the patients have severe bleeding hematemesis after receiving streptokinase. It is a thrombolytic agent, indicated excessive fibrinolysis, and need to reverse the anticoagulant effect. So the other options, the factor VIII concentration used to treat the hemophilia, and this the amino carbonic acid is antifibrinolytic agent. It's reverse the streptokinase. Protaminase, it's used to reverse the anticoagulant effect of heparin, and the vitamin K is antidote for warfarin. So you have to know this amino carbonic acid is antidote for streptokinase. And this streptokinase we use if we cannot do the BCI immediately. Okay, 50 years old man who work as bank employee, discharged following 7-day admission for acute myocardial infarction. He was given 5 different drugs. What further information regarding lifestyle and daily activity should be given to him? Should you advise him to change his job, or start driving 2 days after discharge, or referring him from sexual activity for 3 months, refrain from sexual activity, or perform mild aerobic exercise from next week? So course, we're not gonna advise him to change his job, and we're not gonna start driving after 2 days. This is all unreasonable causes. The correct answer will be anaerobic exercise. We need about 150 minutes for moderate intense exercise weekly, and this starts after 1 week. After 1 week from the discharge. Okay. 48 years old woman is seen in the clinic because of recurrent severe nocturnal chest pain for several months. That rapidly resolved with nitrate, sublingual nitrate. She had normal cardiac catheterization and positive ergonovine echo testing. So she does not want to use multiple medication, and she accepts only use one drug as the long-term maintenance therapy. Which of the following drug is the best strategy for long-term management of this patient? So these patients have recurrent severe nocturnal chest pain, normal cardiac catheterization, so vasospastic angina. When you see normal catheterization, this is most likely to be vasospastic angina. So positive ergovine echo testing. So which of the following will be long-term management? The answer will be definitely not lisinopril, not carvedilol, not aspirin. It will be nivedipine. Why it's nivedipine? Because this is vasospastic angina, pastly known as Prinzmethyl angina. Lisinopril AC inhibitor used for hypertension and heart failure, not for vasospastic angina. Beta blocker also avoided in vasospastic angina. Nivedipine is the correct answer because it's calcium channel blockers and highly effective in preventing the coronary artery spasm, preferred for long-term maintaining of vasospastic angina. Aspirin is anticoagulant, as you know, used for atherosclerotic disease, not primarily for vasospastic angina. So vasospastic angina, you have to know that vasospastic angina characterized by recurrent severe nocturnal chest pain, rapidly resolved with sublingual nitrate and normal cardiac catheterization. This rule out significant atherosclerotic heart disease and typical for vasospastic angina. And also we have positive ergovine echo testing. Ergonovine is provocative agent used to induce the coronary artery spasm, from confirming the diagnosis of the vasospastic angina. And this is important information you have to know for this exam. Okay. This is 65 years old man with diabetes and hypertension, admitted with extensive anterior ST elevation MI. So he has successful angioplasty and testing, understanding and stenting to the left anterior descending to the large artery. Aspirin, clopidogrel, and bisoprolol and enalapril were started. So he received these drugs for so cholesterol HDL was low, the HDL it's 1, the LDL was 3.36, the total cholesterol was 5, and the TG was 2.2. So which of the following is the recommendation for this patient? So we have to know the cholesterol treatment for certain patients. So he is not taking cholesterol lowering agent, so we're going to go give him atorvastatin. So STEMI patient has significant cardiovascular risk, including diabetes, hypertension. So according to the current guideline, patients with clinical atherosclerotic cardiovascular disease include history of MI, should be on high intensity statin therapy. So diabetes, patient age 40 to 75, with LDL between 1.8 to 4.2, 4.9 should be received moderate to high intensity statin therapy. So these patients have have fit the criteria. So the other options are clearly strong. As we say, I'm not explaining a lot, I'm just reading the questions and the answers. So this is 60 years old, diabetes, hypertension, admitted for coronary care unit, diagnosed with unstable angina. Physical examination normal except for S4. So he received aspirin, bisoprolol, and enoxaparin, atorvastatin, and nitrate. Start blood pressure normal, heart rate normal, respiratory rate normal, troponin 0.001. ECG show ST depression in lead 2, 3 AVF, and the echo is normal. What additional medication is indicated? So let's see. Well, he has unstable angina. The first thing we have to think about in the unstable angina is to give anticoagulant. So clopidogrel, candistatin, his blood pressure is normal. We will not give him, and he already taking. He's not taking. Okay, he's already taking atorvastatin. Streptokinase will unlikely be here, only if it was STEMI. So he have no ST elevation. So streptokinase will be unlikely here. Spironolactone is not at all. It's not used in the ischemic heart disease. Okay. So the non-STEMI, the patient has non-STEMI, so he's already in medication aspirin, bisoprolol, enoxaparin, atorvastatin, nitrate for the symptoms. So the standard management must be including the clopidogrel. So adding clopidogrel to aspirin complete the dual antiplatelet therapy. It's antiplatelet, not anticoagulant, as I mentioned. So sorry. So it's a crucial component for non-STEMI. So it prevents the recurrence of the ischemic. So next question. I guess we take too long for simple questions. So this is 70 years old. Admitted for stomach resection gastric cancer. On the fourth post-operative day, the patient developed retrosternal pain, chest pain, accompanied with dyspnea and perfuse sweating. Physical examination is remarkable only for S2. Only for S4, sorry. Aspirin, clopidogrel, and nitrate were administered. Blood pressure is normal, heart rate normal, respiratory rate normal, temperature is normal, oxygen normal. ECG show ST elevation in the anterior leads. Which of the following is the most appropriate management? So this one has retrosternal chest pain and dyspnea and perfuse sweating and have STEMI. So what's the most appropriate step in the management? Thrombolytic therapy, primary angioplasty, abeximab, warfarin. So mainly we'll go for primary angioplasty. The PCI is the most important therapy for STEMI. Okay. So for STEMI, urgent reperfusion is critical. Primary percutaneous or the PCI is the preferred method, especially when fibrinolytic therapy is contraindicated due to recent major surgery. So this patient has a recent major surgery, so we cannot use fibrinolytic or streptokinase. So PCI and angioplasty is the answer. 60 years old, hypertension, present. Sorry, just 1 minute. Okay, sorry. So 60 years old man with hypertension present to the emergency room with sudden onset retrosternal pain, dyspnea and palpitation for 2 hours. His past medical history is significant for non-hemorrhagic stroke 2 months ago. ECG show ST elevation in lead 2, 3 IBS, the inferior leads. So the chest radiography shows cardiomegaly, ECG, left ventricular hypertrophy. Which of the following is most appropriate treatment? So this has sudden retrosternal chest pain, dyspnea, palpitation, and he has he has ST elevation. So this is STEMI. So the most appropriate treatment will be visit fibrolytic therapy. Aspirin will roll out now, and fractionated will roll out, as you know. So BCI or fibrolytic therapy. Okay, we almost always go for BCI in every patient has a risk factor or recent stroke. So this patient has a recent stroke, non-hemorrhagic stroke 2 months ago, or even if it was post-operative or something like this. Almost always we will go with BCI. Okay, this is the recall. Okay. This is 62 years old woman who is known to have diabetes mellitus, type 2 hypertension, dyslipidemia, ischemic stroke 1 month ago. Presented to the emergency room complaining of central chest pain, stabbing continuous chest pain for 3 hours. She denies any dyspnea, palpitation, or change in consciousness. The patient is taking insulin, lisinopril, metoprolol, Lipitor, and aspirin. Examination revealed she is in pain. She was started on oxygen, morphine, and sublingual nitrate, nitroglycerate. Which of the following is the most appropriate next step? So this has ischemic stroke 1 month back, 2 line under this, and has central stabbing, continuous chest pain. So the long duration of symptoms suggests it's MI and not angina. The angina will not be that much long for 3 hours. Okay. So the next step, should we give him magnesium, do CT angiography, or urgent coronary angiography, or give thrombolytic? There is no time. This is obviously wrong, and there is no time for CT. We will urgent angiography. So this patient history of ischemic stroke 1 month back, critical piece of information: recent stroke within 3 months, absolute contraindication for thrombolytic therapy due to significant increases of the intracranial therapy. And the other options is understood why it's wrong. Okay, this is a simple question. Which of the following is absolute to line under absolute contraindication for thrombolytic therapy? Is it pregnancy or intracranial hemorrhage, or cardiopulmonary resuscitation for 10 minutes, or blood pressure at high blood pressure 180? So there's a lot of contraindication, but the absolute contraindication is intracranial hemorrhage, and we mentioned this before. So the question asks for absolute contraindication, referring to provide table contraindication. Okay, so the acute contraindication. This information, there is a book or slides. We will share it with you in this website, and the link will be in each question. So the absolute typical absolute contraindication: 1, known cerebral arteriovenous malformation, known cerebral neoplasm, primary or metastasis, ischemic stroke within 3 months, and suspected aortic dissection, active bleeding or bleeding diathesis, significant trauma within 3 months. So, and added to that, prior intracranial hemorrhage. So this is all absolute contraindication. You have to keep it in mind. If you have ever had prior intracranial hemorrhage, this will be absolute contraindication for streptokinin or thrombolytic therapy. Okay. This is 49 years old, smoker, type 2 diabetes, morbid obesity, recent diagnosis of symptomatic peripheral artery disease. He started on atorvastatin, offered supervised exercise program, and discussed smoking cessation and intervention. Which of the following should be recommended to prevent cardiovascular events? So this the recommended to prevent cardiovascular event is it aspirin, warfarin, atenolol, and enoxaparin. I guess the answer is obviously, even if you are not medical, you will know the answer. So the aspirin is the first line antiplatelet recommended for secondary prevention of cardiovascular event especially in patients with established ASCVD, including symptomatic bad torque, inhibiting platelet, reducing risk factor for thrombus and myocardial infarction and stroke. We all know this. So aspirin is the recommended for the cardiovascular event. Okay, we have last two questions or three questions. 60 years old, type 2 diabetes, present with persistent diffuse neck pain, and past hour diaphoresis, shortness of breath, normal troponin 1 level, and electrogram that reveals only non-specific ST segment and T waves change. Which of the following is the most appropriate next step in the management? So, should we do the administer oral ibuprofen, or recheck the troponin level in 6 hours, perform right-sided electrocardiogram, ECG, administer aspirin and sublingual nitroglycerin. So there is button or chest pain button that suggests acute coronary syndrome. We will explain it. So here we're gonna give him aspirin and sublingual nitrate. So this patient presents with acute coronary syndrome, persistent diffuse neck pain, diaphoresis, shortness of breath. He also has type 2 diabetes, which is risk factor for coronary artery disease. Okay, can present with atypical symptoms of acute coronary syndrome, while his initial troponin is normal. ECG show non-specific change. So acute coronary syndrome cannot be rolled out immediately. Okay, so why we administer aspirin and sublingual nitrate? This is the part of the immediate and standard initial medical management for any suspected acute coronary syndrome. Aspirin should rapidly inhibit the platelet aggregation, reduce the clot formation. Nitroglyceride provide the vasodilation to relieve the ischemia. So this should be administered promptly and unless contraindication. So unless there is contraindication, we're gonna give the aspirin and nitroglycerin. So contraindication like the severe hypertension for nitroglycerin. The provided image flow chart for the chest pain, flattened acute coronary syndrome, show aspirin, nitroglyceride for 5 minutes. This is a nice picture. I guess I didn't add it here, but will be sent for you, inshallah. Okay. The last two questions, I guess there are, okay, easy questions. 39 years old man is admitted to the hospital with inferior lateral myocardial infarction. Which of the following medication would improve his survival? Okay, hydrochlorothiazide, metoprolol, morphine, or warfarin. Okay, so what's the drug that improves the survival? We know that the drugs that improve the survival, it's ACE inhibitor, then beta blocker, and statin, and low dose aspirin. You should remember these 4 drugs that's improve survival for the MI patient. So here the correct answer will be beta blocker. So I guess it's not mentioned here, but anyway, you have to know the 4 drug that's improve the mortality, and it's like what we say, ACE inhibitor, beta blocker, statins, and low dose aspirin. Okay, this is the last question in this session. 60 years old with diabetes, hypertension, present to ER with 3 hours continuous retrosternal heaviness associated with profuse sweating. So heaviness associated with profuse sweating. Physical examination revealed tachycardia is for auscultation. The patient is commenced on aspirin, clopidogrel, metoprolol, and nitroglycerin infusion. ECG sinus tachycardia with left bundle branch block. Previous ECG was normal. Cardiac enzyme bending, which of the following most appropriate next step in management. So this patient has bundle branch left bundle branch block. So when you see this with these symptoms, it's raised the suspicion of ST elevation MI. This is raised the suspicion for ST elevation MI, especially with these symptoms: retrosternal heaviness associated with profuse sweating. So when we think about there is previous ECG normal and cardiac enzyme bending, so next step will be which of the following? Start lidocaine infusion. Lidocaine is antiarrhythmic, so it's not used in the left bundle branch block. Perform exercise ECG testing. He has now acute chest pain, so this is not very fair. Administer thrombolytic therapy. Wait for the result of cardiac enzyme. This is high suspicious state, so no need for waiting for the cardiac enzyme. So either we start the BCI. If there is BCI, we're gonna go with the BCI, but there is no BCI, so the correct answer will be thrombolytic therapy. Okay, so this is, we're gonna treat it as STEMI. So a new or presumed new left bundle branch block in the presence of symptoms suggesting C ischemia is considered STEMI equivalent, requiring urgent reperfusion therapy, primary BCI or fibrinolysis without delay for cardiac enzyme result. So that's all, and this is fast just review for the question. Thank you for watching. I hope you enjoy. So we're gonna see you in the next session after BCI, bradycardia and tachycardia.